Welcome to the May 2017 podcast from the Journal of Bone and Joint Surgery. This month, our podcast features abstracts of 4 scientific articles published in the May issues of the journal, as well as commentaries by Dr. Christopher Bibbo on the article entitled Synovial Fluid Cell Count for Diagnosis of Chronic Periprosthetic Hip Infection, and Dr. Mark J. Adamczyk on the article entitled Leptin Elevation as a Risk Factor for Slipped Capital Femoral Epiphysis, Independent of Obesity Status. Be sure to check out this month's Current Concepts Review article on surgical management of acute distal biceps tendon ruptures by Dr. David Savin and colleagues. The authors point out that acute distal biceps tendon ruptures are uncommon but potentially debilitating injuries that often affect young active males and typically result from an eccentric load on the dominant upper extremity. Surgical treatment may be indicated to prevent substantial weakness in supination and flexion that can occur with non-operative treatment. Non-operative management should be reserved for elderly or less active patients with multiple comorbidities, especially when the injury involves the non-dominant arm. In this issue, JBJS.org presents a new image quiz, a 66-year-old man with worsening knee pain. Be sure to visit us online to access these features, as well as the full text of the scientific articles you are about to discover in the following podcast. Next, you'll hear the first abstract of 4 that are being presented in this podcast. This abstract is from the article entitled Synovial Fluid Cell Count for Diagnosis of Chronic Periprosthetic Hip Infection by Dr. Carlos A. Higuera and Associates. Investigation performed at the Rothman Institute at Thomas Jefferson University Hospital, Philadelphia, Pennsylvania. There is a paucity of data regarding the threshold of synovial fluid white blood cell WBC count and polymorphonuclear cell neutrophil percentage of the WBC count PMN percentage for the diagnosis of chronic periprosthetic joint infection PJI after total hip arthroplasty. Despite this, many organizations have provided guidelines for the diagnosis of PJI that include synovial fluid WBC count and PMN percentage. The authors attempted to define a threshold for synovial fluid WBC count and PMN percentage for the diagnosis of chronic PJI of the hip, using a uniform definition of PJI, and to investigate any variations in the calculated thresholds among institutions. From 4 academic institutions, the authors formed a cohort of 453 patients with hip synovial fluid cell count analysis as part of the workup for revision total hip arthroplasty. Using the definition of PJI from the Musculoskeletal Infection Society, 374 joints were diagnosed as aseptic and 79 as septic. Intraoperative aspirations were performed as routine practice, regardless of the suspicion for infection, in 327 of the patients. Using receiver operating characteristic curves, the optimal threshold values for synovial WBC count and PMN percentage were identified. For the diagnosis of chronic PJI of the hip, the threshold for the overall cohort was 3,966 cells per microliter for WBC count and 80% for PMN percentage. Despite the high predictive accuracy for the cohort, there was notable institutional variation in fluid WBC count and PMN percentage. Furthermore, the rate of PJI was 14% for patients with a WBC count of 3,000 to 5,000 cells per microliter, compared with 91% for patients with a WBC count of greater than 50,000 cells per microliter. Similarly, the rate of PJI was 29% for patients with a PMN percentage of 75 to 85%, compared with 69% for patients with a PMN percentage of greater than 95%. Conclusions. Using the MSIS criteria, the optimal synovial fluid WBC count and PMN percentage to diagnose chronic PJI in the hip is closer to thresholds for the knee than those previously reported for the hip. This study validates the diagnostic utility of synovial fluid analysis for the diagnosis of periprosthetic hip infection. However, the authors also identified a clinically important gray area around the threshold for which the presence of PJI may be unclear. Next, you'll hear a commentary by Dr. Christopher Bibbo on the article entitled Synovial Fluid Cell Count for Diagnosis of Chronic Periprosthetic Hip Infection.
This is Dr. Christopher Bibbo providing commentary for the May 2017 JBJS podcast. I will be providing commentary on the article entitled Synovial Fluid Cell Count for Diagnosis of Chronic Periprosthetic Hip Infection. The title of my commentary is Groundhog Day Again? You be the judge. Diagnosing periprosthetic joint infection, PJI, remains a vexing task with the tools that we have for making a definitive diagnosis. Periprosthetic knee infection has been the model on which other PJI evaluations are based. The hip is no different, except that PJI of the hip may be more difficult to evaluate as access to synovial fluid is more challenging and samples are precious. Controversy over the diagnosis of PJI has been the progeny of the modalities utilized. The historical method and the current mainstay for a large number of institutions is an analysis of synovial fluid, white blood cell count, and differential cell assay. Perhaps it is why PJI diagnosis using synovial fluid white cell count is often revisited. Such analysis is relatively easy to perform, imports low morbidity, and is less costly than an operative evaluation, and gives hope to the result of a true negative. After all, is it not the diagnosis of hip PJI synovial fluid analysis with the elimination of false positive and false negative results, and with the establishment of the optimum breakpoint our goal? In the current study, Higuera et al. Provide insight into the utility of synovial fluid analysis of PJI or the hip. More importantly, they describe a diagnostic gray area regarding synovial cell counts and neutrophil percentage of the white blood cell count, the zone for which we must evaluate synovial fluid values with a critical eye. This gray area is the region of the receiver operating characteristic curve that may be used as fertile ground for the use of other modalities, such as alpha defensin assay, to diagnose PJI, as well as for the development of new technologies to accurately diagnose PJI. Orthopedic surgeons who perform total hip arthroplasty will, by default, need to manage PJI and should welcome the information provided in this study and use the data as an impetus to think critically about the synovial fluid cell count in the setting of a potential PJI. The findings of this article contribute to solving our diagnostic dilemma. Hopefully, in the near future, the diagnosis of PJI will be a singular test.
Next, you'll hear the second abstract of 4 that are being presented in this podcast. This abstract is from the article entitled Return to Play and Patient Satisfaction After ACL Reconstruction, Study with Minimum 2-Year Follow-Up by Dr. Benedict U. Wachukwu and Associates. Investigation performed at the Hospital for Special Surgery, New York, New York. Return to play and patient satisfaction after anterior cruciate ligament reconstruction, ACLR, have been inconsistently studied. The purposes of this study were to 1. Investigate rates and predictors of return to play after ACLR, 2. Evaluate patient satisfaction after ACLR, and 3. Analyze the relationship between return to play and satisfaction with the result of ACLR. Eligible patients were active athletes included in an institutional ACL registry who had undergone ACLR and had been followed for a minimum of 2 years. A questionnaire was administered to elicit information regarding factors associated with return to play, sports performance, re-injury, and overall patient satisfaction. The Wilcoxon-Mann-Whitney-U test was used to compare return to play with patient satisfaction. Multivariable logistic regression was used to identify demographic, sports, and clinical factors associated with return to play. 232 patients with a mean age of 26.7 years, who had been followed for a mean of 3.7 years, were enrolled. Of 231 patients who responded to the return to play question, 201 had returned to play at a mean of 10.1 months. Of 175 athletes eligible to return to their prior level of competition, 89.1% had done so. Overall satisfaction was high. 85.4% were very satisfied with the outcome, and 98.1% stated that they would have surgery again. Patients were more likely to respond very satisfied if they had returned to play. Use of a patellar tendon autograft increased the chance of returning to play, whereas playing soccer or lacrosse preoperatively decreased the likelihood of return to play. Conclusions. The rates of return to play and patient satisfaction are high after ACLR in active athletes. The use of patellar tendon autograft increased the likelihood of returning to play, whereas pre-injury participation in soccer and lacrosse decreased these odds. Additionally, patients who returned to play were more likely to be very satisfied with the result of the ACLR. Next, you'll hear the third abstract of 4 that are being presented in this podcast. This abstract is from the article entitled Leptin Elevation as a Risk Factor for Slipped Capital Femoral Epiphysis Independent of Obesity Status by Dr. Schuyler J. Halverson and Associates. Investigation performed at the Monroe Correll Jr. Children's Hospital at Vanderbilt Medical Center, Nashville, Tennessee. Slipped capital femoral epiphysis, SCFE, is strongly associated with childhood obesity, yet the prevalence of obesity is orders of magnitude greater than the prevalence of SCFE. Therefore, it is hypothesized that obesity is not by itself a sufficient condition for SCFE, but rather one component of a multifactorial process requiring pre-existing physical pathology. Leptin elevation is seen to varying degrees in patients with obesity, and as leptin has been shown to cause physical pathology similar to the changes seen in SCFE, the authors propose that leptin may be a factor distinguishing between patients with SCFE and equally obese children without hip abnormalities. Serum leptin levels were obtained from 40 patients with SCFE and 30 control patients with approximate body mass index BMI matching. BMI percentiles were calculated according to Centers for Disease Control and Prevention population data by patient age and sex. Patients were compared by demographic characteristics, leptin levels, odds of leptin elevation, and odds of SCFE. The odds of developing SCFE was increased by an odds ratio of 4.9 in patients with elevated leptin levels, regardless of obesity status, sex, and race. When grouping patients by their obesity status, non-obese patients with SCFE showed elevated median leptin levels at 5.8 nanograms per milliliter, compared with non-obese controls at 1.7 nanograms per milliliter. Similarly, obese patients with SCFE showed elevated median leptin levels at 17.9 nanograms per milliliter, compared with equally obese controls at 10.5 nanograms per milliliter. Serum leptin levels increased in association with obesity, with an increase in leptin of 0.17 nanograms per milliliter per BMI percentile point. Conclusions. To the author's knowledge, this study is the first to clinically demonstrate an association between elevated serum leptin levels and SCFE, regardless of BMI. This adds to existing literature, suggesting that SCFE is a multifactorial process, and that leptin levels may have profound physiological effects on the development of various disease states. Despite a strong association with adiposity, leptin levels vary between patients of equal BMI and may be a vital resource in prognostication of future obesity-related comorbidities. Next, you'll hear a commentary by Dr. Mark J. Adamczyk on the article entitled Leptin Elevation as a Risk Factor for Slipped Capital Femoral Epiphysis Independent of Obesity Status.
This is Dr. Mark J. Adamczyk providing commentary for the May 2017 JBJS podcast. I will be providing commentary on the article entitled Leptin Elevation as a Risk Factor for Slipped Capital Femoral Epiphysis Independent of Obesity Status. The title of my commentary is The End of the Road for Idiopathic Slipped Capital Femoral Epiphysis. In the article, Leptin Elevation as a Risk Factor for Slipped Capital Femoral Epiphysis Independent of Obesity Status, Halverson et al. Investigate the concept that elevated leptin levels may predispose any child to developing a slipped capital femoral epiphysis, or SCFE, regardless of his or her weight determined by BMI. Despite the well-published association between SCFE and obesity, this study is based on the observations that there are many more children who are obese than who develop SCFE. Most patients who develop SCFE do not have identifiable underlying endocrine or metabolic disease, i.e. the cases are idiopathic. Hyperleptinemic animal models demonstrate physical findings similar to those of patients with SCFE, and both patients with SCFE and those with hyperleptinemia have higher rates of obesity and hypertension than control patients. Bringing this concept together through case-controlled comparison, the authors demonstrate that patients who develop SCFE routinely show elevated leptin levels compared with BMI-matched controls, no matter the age or BMI status, suggesting a causal relationship between the two. As a preliminary association in need of further study in a larger context, multi-center reproduction of results, This finding allows the possibility of eliminating the diagnosis of idiopathic SCFE. As is often frustrating in the clinical orthopedic practice, the diagnosis of exclusion represented by an idiopathic condition, in this case SCFE, frequently leaves the surgeon, patient, and family lacking a satisfactory explanation of the patient's current situation. By enabling a specific diagnosis to be made, in this case hyperleptinemia, as the authors mention, a specific cause for the problem is identified, and the search for other known medical conditions linked to elevated leptin levels, for example, cardiovascular, endocrine, and pulmonary disease, may be undertaken with the possibility of proactive treatment and preservation of the patient's health. If further proven to be a causal relationship associating hyperleptinemia with the diagnosis of SCFE and its readily observable pain and limp, the ramifications of elevated leptin levels are clarified in a much more obvious way than many of the other associated problems, such as hypertension, that may take decades to become manifest in daily life and that may be at a late stage, stroke or heart failure, before detected. This may lead to additional urgency in the patient and family toward proactive management and avoidance of additional future health issues. It also places the orthopedic surgeon in the particularly critical position of being able to demonstrate in a concrete and immediate way the possible negative health consequences of hyperleptinemia, allowing other medical providers to move the discussion to other areas with further patient health benefit. As the authors demonstrate in this article with regard to SCFE and hyperleptinemia, combining the findings of clinical and basic science orthopedic studies with those of other medical arenas may lead to the elucidation of the true cause of further idiopathic diagnoses such as Blount disease, Legg-Calvé-Perthes disease, and scoliosis, with a possible additional health benefit to our patients beyond their orthopedic care.
Next, you'll hear the last abstract of 4 that are being presented in this podcast. This abstract is from the article entitled Sclerostin Antibody Treatment Enhances Rotator Cuff Tendon-to-Bone Healing in an Animal Model by Dr. Shivam A. Shah and Associates. Investigation performed at Washington University in St. Louis, Missouri. Rotator cuff tears are a common source of pain and disability, and poor healing after repair leads to high re-tear rates. Bone loss in the humeral head before and after repair has been associated with poor healing. The purpose of the current study was to mitigate bone loss near the repaired cuff and improve healing outcomes. Sclerostin antibody treatment, previously shown to increase bone formation and strength in the setting of osteoporosis, was used in the current study to address bone loss and enhance rotator cuff healing in an animal model. Sclerostin antibody was administered subcutaneously at the time of rotator cuff repair and every 2 weeks until the animals were sacrificed. The effect of sclerostin antibody treatment was evaluated after 2, 4, and 8 weeks of healing using bone morphometric analysis, biomechanical evaluation, histological analysis, and gene expression outcomes. Injury and repair led to a reduction in bone mineral density after 2 and 4 weeks of healing in the control and sclerostin antibody treatment groups. After 8 weeks of healing, animals receiving sclerostin antibody treatment had 30% greater bone mineral density than the controls. A decrease in biomechanical properties was observed in both groups after 4 weeks of healing, compared with healthy tendon-to-bone attachments. After 8 weeks of healing, sclerostin antibody-treated animals had improved strength and stiffness compared with control animals. Histological assessment showed that sclerostin antibody promoted better integration of tendon and bone by 8 weeks of healing. Sclerostin antibody had significant effects on gene expression in bone, indicative of enhanced bone formation, and no effect on the expression of genes in tendon. Conclusions. This study provides evidence that sclerostin antibody treatment improves tendon-to-bone healing at the rotator cuff by increasing attachment site bone mineral density, leading to improved biomechanical properties. Thank you for listening to this JBJS podcast. Please visit www.jbjs.org for commentary and perspective on many of the articles presented in this podcast, and for more content of interest.